Just so you know, we've had some people request to record the task force meeting. We record the meeting and then we put it up on the state attorney website. Generally comes up about a week after we get it up. We get it up on the site. So we can't have others record it because it knocks us off. At least that's what I'm told from a technical standpoint. But welcome, everybody. We had a couple of technical difficulties. I am not seeing all the uh, participants on the screen. Why am I not? Okay. Yeah, gallery. There we go.
Okay, go ahead.
All right, welcome. Let me get right into it. From the healthcare district, do we have anybody here from the healthcare district? Dr. Andriek, Dr. Phillips? Anybody here from the healthcare district?
Yeah.
Going once. They presented last meeting a couple months ago, so I guess they're sitting this one out. Tom Baird, attorney, Foster Jones Foster. Tom?
No.
Okay, Turner Benoit from Hanley. Turner? I think he'll be joining us. Ann Berner, she'll be giving a presentation later on from the South Florida Behavioral Health Network. Ann?
This is Daniel Oria. I'm actually covering for Anne. She wasn't able to be here today. I apologize, but I'll be doing the presentation on her behalf.
All right, Daniel, thank you. Okay, Ariana Ciancio from Delray Beach PD. Ariana, would you reach out to Ariana, please? Thank you. Dr. Anita Kokovas, Executive Director for the Community Recovery, the Hub, Palm Beach County. Dr. Kokovas? Boy, I'm just striking out left and right here. Uta Gaziak from Florida Behavioral Health Association. Uta, you with us?
Yeah.
All right, will you reach out to Uta as well?
Al,
Yes.
Anita is no longer with the hub.
Oh,
Holly Stewart is the executive director. I don't know if she's gotten an invite or not.
okay. Is it Ann? Did you say Ann Stewart?
Holly,
Holly Stewart. All right, we will,
I can shoot you her email later.
yeah, or if you can shoot her an email now,
Okay.
and
Yeah.
if we get her email address on the chat,
Yep.
we'll send her the coordinates.
Okay. I
This
was
is
going
a
to say, I
yeah.
can just forward her the invite.
Oh, sure, that'd be great.
Yep.
That'd be great.
Yep. No problem.
Appreciate it. Okay,
Of
Dr.
course.
James Green, or is there anybody from Palm Beach County Community Services?
Good
All right.
afternoon. This is Dr. Joanna Reedy Noyes here, and
Oh,
also Jill Singer.
hi, Dr. Noyce. Good to see you again. And
Nice to see you too. And we also have Jill Singer on the call as well.
Jill Singer, okay.
Yeah.
That's excellent. And you're doing some great things. I enjoyed your presentation last time, and I know they're speaking to other folks that the county is really stepping up to the plate with the opioid dollars, and thank you for that. Kelly
No problem.
Lee,
It's a team effort. Thank you.
Kelly Lee, DCF, or anybody from DCF with us? There's got to be somebody from DCF because we have a presentation coming up.
Yes, sir. It's Angela Shave from
Okay.
DCF. How are you doing?
Hi, Angela. Welcome. I look forward to seeing a demonstration of the new Leads platform. I know Jeff Lynn has a hearing and couldn't make it today. Nancy McConnell, Rebel Recovery. Nancy? Spoke to Neil McGarry earlier on. Neil from Florida Certification Board. Yeah, I know Neil's going to be on. Oh, I think he is traveling, and so he can't speak. Okay. Michael McKeon from Oxford House. Michael?
I'm here, Al.
Hi, Michael. I'm really looking forward to the documentary tomorrow night at the
Yes.
Travis. I'm sure
Awesome,
there'll be a big crowd, and I'm sure you're going to mention it during your numbers.
Yeah.
Dr. Needle, Rachel Needle. Would you reach out to Dr. Needle, please? Terrell Piber and Coconut Creek City Attorney.
Hi, good afternoon. I'll be on till about 2:30, then I have to hop off and then I'll be back on at 3.
Okay, great. Thanks, Terrell.
Thank you.
Susan Ramsey, attorney.
I'm here, Al. Here I
Hi.
am, live and in person.
Okey doke. I saw Terry Shapiro front and center. Terry Shapiro with Executive VP GIA Miami and Vita Recovery.
Banyan Treatment Centers.
Well, yeah, that I know. Didn't know that was part of your.
Yeah.
Should I strike the others?
Yeah. Yep. Yeah. Banyan Treatment Centers, full-time, 100%.
Okay. All right. Thanks for that. Nikki Soda Consulting. She can't make it?
She just emailed me.
Okay. All right. She just let us know. Dr. Semenides of FSAM, Florida Society of Addiction Medicine. I'm surprised he's not here too, if you could reach out. He may have signed in and signed out. Okay. Alton Taylor Drug Abuse Foundation. Alton, or is it
Stephanie Thompson for Alton.
Okay, great. Thank you. And Jan Toman, South Florida Opioid Alliance. I did see Dr. Lori Vinacore, Alliance for Delray Residential Associations.
Hi, I'm here.
Hi, Dr. Vinacore.
Good to see you.
Greg Weiss or somebody from Greg Weiss's office at the county?
He is not coming, but the Commissioner Weiss is not coming.
Okay, right, yeah. Okay. Eric Urlano, Integrity Billing. Okay. Thank you all for coming and being part of the meeting for the month of June. Our next meeting will be in August. We'll shoot you out the date when we secure the date. Trying to get this live at some point. We're working with the healthcare district, but they don't have very many dates available. DAF as well. If anybody wants to, when we're in the chat or something like that, if you have a hybrid location that can do live and also Zoom, because we have a lot of people that show up that are out of state or out of the county. But I do want to come back at least to hybrid, going back to live, the live meetings. Okay, updates. Let's get this up on the screen.
Wait, I gotta get yours.
Yeah.
Hold on.
There we go.
No, I have to download it. Give me 1 second.
Oh, yep.
Should be in a second.
Oh, sorry for the delay, everybody. We had a technical difficulty before the meeting. And one of the technical difficulties is I wrote the wrong dates in on my slides for the stats and had them corrected 10 minutes before the meeting. So my bad. We'll get it in a second.
We should have it now.
But you know what? It's worth waiting for the news is pretty good. That would be the top one to the right, or the bottom one to the right. Okay.
No.
Uh,
Is that your correct one?
I'll know by the second slide. Okay, this we have the numbers from our medical examiner for 2025. I know the rest of the state we will not get numbers statewide until probably November, early December from the Florida FDLE medical examiners, Florida medical examiners. So looking to 24 and 25 for comparatives, we have no pending cases, obviously, in 25 because we're already in June. We can see that the numbers, the total drug overdoses have decreased by about 80. And same thing with the total opioid ODs. So we've gone from 244 in 24 to 166 in 25, which is a 32% decrease. Fentanyl, of course, covers around 90% of the ODs, and it still is up there close to 90%. The next slide is going to be, here we go. Yeah, because you have to do that.
No, stop.
Well, let's try. All right. Poltergeist, that's what the next slide is. Being
No, I can't move it.
all right.
Go
You all should have gotten a copy of the attachment when you got the coordinates for the meeting. That's the public as well. Sorry, I'm just going to have to read this off of a sheet, but we have medical examiners' numbers, and this is a snapshot because there are pending cases that that they're awaiting toxicology reports for 2026. But we have the first 5 months, actually through June 1st, but that would be the first 5 months of 2026. So in the first 5 months of 26, with 16 pending cases, there were 87 overdose cases, deaths, and 40 due to opioids. I believe that's number's low. It's less than 50% of the total drug overdoses, but those are the numbers right now with 16 pending cases. Total fentanyl was 37, which is 93%. The numbers in the snapshot represent another 54% decline, which would bring us at the end of the year under 100, which is tragic, of course, but phenomenal when you look at the difference between, say, 2017, when we had 647 opioid overdose deaths, to now, where we're looking to be below 166 for sure. Even if you add the 16 pending cases to the 40, it'll still give us about a 35% decrease on 26 the first 5 months over 25 the first 5 months. Anybody have any questions about this? And I'm sorry I couldn't pull this up onto the screen. Again, my bad. So any comments or questions? Okay. We're certainly going in the right direction here in Palm Beach County. It's going to be interesting to see the medical examiner's report that comes out. Again, it's going to be 2025. And I would say that throughout the state, you're going to see a drastic decrease. And we have been trending higher than the rest of the state in terms of the decrease in opioid overdose deaths through the medical examiner. It's an all hands on deck. It's the task force is a good thing, but everybody's cooperating. All the silos are moving in the right direction, and we do have much better oversight through state law, and with FAR as a certifying entity. And I'll let them give them their thunder when Josh Thrasher talks about the numbers this month. The next slide is Palm Beach County Fire Rescue. In 2025, we had a 39% decrease in transports due to drug overdose or suspected drug overdose. The net change between 2017 and 2025, 72% reduction in transports, which is a huge savings. The burden on the county and also the municipalities who have their own fire departments. We had estimated the county alone, which is about 50% of the transports in 2017, was spending about $6 to $7 million on just this issue of transporting suspected drug overdose. And the number in 2017 was 2,675 transports, a number of which were 2 people overdosing, multiple people overdosing. 2025, the full year, down to 745. Again, a 72% decrease over the course of the 9 years. And this year, for the first 5 months, we've got a further decrease, which the net decrease in the first 5 months. So we went back and looked at all the numbers from 2017 to 2026. In the first 5 months in 2017, there were 1,278 calls for suspected overdose. In 2026, first 5 months, 244, which now is a net decrease of 81% in transports. Not only a savings in lives, I mean, in Palm Beach County, we've really got a twist on this. The healthcare district, the managing entity, fire rescue, the hospitals, especially JFK North, is equipped through the healthcare district of processing people through with actual personnel that are on duty at the hospital that are addiction specialists. So, hey, it's still there. The war is not over, but we are doing a great job statistically. Now I want to move over to FAR. Josh,
I have
to give us the FAR update?
Al, I have a question before we
Yeah.
move on. I was wondering if you had any insight into the supply and enforcement side of things, because I mean, I know all the work we're doing on the on
Oh, is this
our end,
Daniel?
right?
Is this Daniel Oria?
Yes.
Oh, okay. All right. Normally we take questions from the group, but because we don't have even 50% of our members here, Daniel, go ahead. What was your statement or question?
Yeah, I'm just curious about, at least from your perspective, on the supply side and on enforcement, right? And in terms of limiting the supply from going into the community, because I think I've definitely heard that there have been changes there. I was wondering if you had any insight into how that has contributed to the decrease. Because I mean, I know all the work we're doing on our end in the behavioral health space and in treatment and addressing all that stuff, but I was just curious if you had any insight into that.
And I apologize,
Yeah.
Daniel. You're here for Ann Berner, so you actually are part of the group. And
Yeah.
and I'm going to give you a couple of examples, okay? Because I don't have there's no hard and fast answer. We have more Narcan available. We have more education available. We have now in state law the recognition that MAT is you can't reject somebody from a recovery house solely on the basis of MAT. So we have, and with FAR and Oxford House, both of whom MAT is, they're following the law. MAT is required unless there's a reason not to allow somebody in. And that's another discussion for another time. But we have, the beds are expanding. The healthcare district and your organization, SEFBEM, we've got opioid dollars that are being turned toward treatment, education. We have the sheriff's office, and the sheriff, kind of like dark humor, says that he runs the largest detox facility in the county, and that's true. But he has dedicated resources. Number one, buprenorphine is now used. There's detox in the jail for both alcohol and drugs. And there are peers that are at the jail. There is treatment at the jail. And so that's a huge bonus. So I think there's a lot of things that contributed. It may even be that the drug cartels are realizing that they're killing their customers. I mean, it could be something like that can contribute to the decrease in fentanyl. There are a lot of reasons, and you can't point to one, since it's happening all over the state and also the country, but not to the degree it's happening in Florida, that we're reducing opioid overdose deaths. I think that all these things are contributing. Like I said, one of the things about this task force, the State Attorney Addiction Recovery Task Force, is to bring people together, different silos together, so we can all work together and people aren't doubling up on their efforts. Rebel recovery, like I said, at the jail. I see we have Lieutenant Fazzino here from PBSO, and he's commented. It's not a question of wanting to do something. It's a question of public safety. It's like the state attorney being involved in this sphere is because it does involve public safety. And kudos to PBSO for recognizing that and stepping up to the plate big time. Many of you all know of people who have gotten out of the jail and continued their path to recovery. We have a drug court that I think is one of the best in the state. And the judges are great at the drug court. So Daniel, it's everything. Any other questions or comments before we get to FAR? Okay, Josh, you're up.
Okay. Thanks, Al. Let me share my screen. It's great to see a lot of those overdose numbers as well as those transports go down. So on the other side of that, we have had an increase in bed capacity since our last meeting. You already know this, I've seen you, but we surpassed the 10,000 beds here a few weeks ago. So we're at 10,154 beds across the state, 294 programs. So levels 1, 2, and 3 is makes up over 5,900 of the beds. Our level 4s, those are the ones that's connected to the treatment that also have housing. It's over 4,100 beds. Broward County makes up over 25% of the beds, while Palm Beach County makes up 35%. Palm Beach County specific numbers, we have 103 providers. We have over 1,700 men's beds, 600 women's, those that serve both genders, all those separate units. There's over 1,100, and we have a few specialized programs for LGBTQ, and that's 21 beds. So Palm Beach County has always been our largest county for FAR certified beds. There has been some notable increases in Duval County, which is Jacksonville. So there's over 100 beds that's been added since our last meeting there. Hillsborough County continues to be a growing area for us. It's over 60 beds added. And we got into a brand new county here last month, Nassau County. So we added one program for 28 beds there. So all in all, FAR continues to grow. I know that 10,000 beds has been a goal for a while. We finally met that. We have a lot of good stuff going on. So what I contribute some of that to is some cross training of staff, which helps the providers through the application process. We are also having more touch points with our providers through quarterly connections, individualized meetings to help them understand what FAR is, what our requirements are. We have templates that we can give them that we explain in detail to them, so we can help them understand how to operate a recovery residence. So we are getting them through the process quicker. So yeah, I also want to mention, Al, we have the NAR Summit that's in September. It's September 26th, 27th, and 28th. It's in Fort Lauderdale this year. So it's the National Alliance of Recovery Residences annual summit. We are the host affiliate this year, and it's going to take place on the beach at the Fort Lauderdale Marriott, I believe. Angie can put the link to the registration in the chat if anyone wishes to attend. It's a really good conference that stakeholders from all over the country come to that. So it's we're happy to be able to host it.
Awesome. Thank you, Josh. Terry, you have your hand up. Do you have a comment or a question?
Yeah, that's great news, Josh. Thank you for that report. Amazing. And I also know that there's two providers coming into Dade County that are going to open sober living in Dade County, two different companies getting ready to, they're moving pretty quickly. I think you guys are aware of that. And in your report, Josh, do you have Heartman House for Women included? I know they just opened up two houses for women.
I'll have to, so I know Hartman's on the report, so I'll have to get with the team on the front end to see if they converted any to a women's or they opened a brand new women's house. But Sean's generally, he's pretty good about notifying the team to make those updates.
Yeah, I know they're approved because I saw everything when I went over to the house and they had an open house. I just didn't know if they were included in your numbers.
They should be. Yeah, if so if they're saying that they're certified and they have the information on the walls, all the FAR certificate, as well as any kind of postings that we required, yeah, I'm sure those are in the numbers. But I'll double check, Terry.
That's awesome. Great job.
Yeah.
Thank you.
Yeah, I want, it's for a long time, we've recognized that Duval County and Miami-Dade were underrepresented. So it's great to hear that you're getting more beds in those two areas.
Mhm.
Speaking of which, and there's no ready answer for this. Talking about underrepresented, Okeechobee County, Josh and I were part of a panel in St. Lucie County last week. And just giving information and hearing from public providers and the like. And apparently there are no FAR certified residences, and I don't believe there are any Oxford houses in Okeechobee County. Is that true?
I remember, Al, from that meeting, I believe someone said there's no sober livings period in Okeechobee.
And that's concerning.
Yeah.
Because historically, and I don't know what the numbers are going to be this year coming up for 25, but Okeechobee County per capita was probably the highest per capita opioid overdose death rate during the crisis. So, I mean, FAR can't, you're reactive. People come to you and they apply. So this is not anything for FAR other than to put all our heads together to figure out there's got to be a need in Okeechobee County. I don't know, and maybe I need to send an email to DCF or maybe maybe Angela, you may know, and even if not off the top of your head, if you could get me this information, are there any providers in Okeechobee County? Are there any level 4 providers which would necessarily have to have a residence involved, or most likely would have to have a residence involved? So it's just something to look at because they're underserved for the population that's in need of treatment and housing. So just turn our attentions to that. We have a hand raised, Maureen Keelian, who put together the Fort St. Lucie gathering. Go ahead, Maureen.
Yeah, I think Barbara Moody is on and she can speak to Okeechobee County. And I know I'm public, she's public, but I'm just saying we have someone online if she's still on. Barbara Moody, who's the RCO leader up here in Port St. Lucie, Treasure Coast. So we might get a good answer there.
Barbara, can you give us the short and skinny on what's going on?
Sure. I just met with the Public Safety County Commissioners this morning out here in Okeechobee, and that was another discussion that we had about FAR certified housing, some type of sober living, some type of respite out here in Okeechobee. There's a couple of places that were offered that we could take a look at. I'm definitely an advocate for FAR. I have been from the beginning, and we are the recovery community organization and peer run led organization in the Treasure Coast, which includes Okeechobee. So we are very familiar with the overdose rates out here, the methamphetamine farms that are out here. We are highly involved, and finally, we have captured the attention of the Sheriff's Department, the Police Department, and the city commissioners, county commissioners. And we're having these conversations now, which, they would never allow to have sober living out here in Okeechobee, but they're recognizing the need. And so these conversations are moving forward. So this is, just this morning at 10:30, I had this conversation with Commissioner Burrows. So thank you so much.
Well, great. Barbara, can you keep us posted on that? You can let Marianne know what's going on. And, we're a task force that's in Palm Beach County, but as you all know, we're statewide in terms of legislation, in terms of what we're trying to do. I'd love to keep a rolling dialogue about what's happening up north. And again, Okeechobee, like Duval, like Miami-Dade, very concerning with the overdose rates. So thank you for
I
that.
would like to have a conversation with you as well, because I am also the co-chair with Ann Berner for our task force. And we're looking at opening a sober home task force in the Treasure Coast within the overdose task force itself. So yeah, I'd like to have another
Sure.
conversation with you offline if possible.
Okay, I'll put you on speed dial.
Thank you.
All right. Okay, one more update, and then we're going to get to the new leads demonstration. Michael, Oxford
Yes,
House.
Al. Thank you. Just on Okeechobee real quick. I actually met with Ann about 2 months ago, and she had mentioned about the severe need out there. And so my staff and I have been looking at that, and I believe Priscilla had met with some of your staff, Barbara. I'm not sure. But we're definitely looking at Okeechobee. It's on our radar. We want to get some houses out there. It is a difficult area with transportation and just the amount of jobs and things like that. And so we want to find a good centrally located location, but it's definitely something that can happen.
Great.
Yeah. So let me share my screen here. So continuing to expand, I think we opened 5 houses since the last meeting at 304 locations at 2,669 beds, 183 men's houses, 51 women's houses, 62 women and children's houses, and 8 men and children's houses. I even put in here, we are looking at some of the more rural areas in the state to really open some new locations. And so that being one of them. Our state association is sending approximately 135 of our members to our World Convention in Denver in September. So we're looking forward to that. We're also planning a women's summit and a men's summit coming up next year. That'll be the first time that we do that. Yeah. The big news is our documentary premiere. So that's actually tomorrow in West Palm Beach at the Rinker Playhouse, which is at the Kravitz Center. If you're interested in coming, if you don't really know much about Oxford House and you might want to learn more, or you just want to network, there's going to be a bunch of people there. Anybody on this meeting is welcome to come. All you need to do is click this link that Marianne shared with everybody in that document. Very easy. It's free, and we would love to have you. And so please come. Al will be there, and we can't wait to see you all. And then also congratulations to FAR, that 10,000 mark. I know you've been going for that for a while, and that's pretty cool to see. So kudos to you all.
All right. I see Terry, your hand is raised. Is that from before or now? Terry?
From before I lowered it, Al. Sorry about
Okay.
that.
Thank you. Any comments, questions? You have 2 articles. I want to get to I know DCF, Angela has a conflict, so we have to get her on now, but just in brief, I would suggest you read the 2 articles. One is about California and the spike of overdoses. And it's very interesting that it's visitors to California, which is precisely the problem that we had in Florida 10 years ago, where 75% of people in private pay were from out of state when we had the worst of the crisis of overdoses. And the other article is Arizona. Arizona is a different kind of fraud. And for people who say that we've won the war in Florida, well, as many of you all know, there is still some fraud and abuse in the industry. But the fraud in Arizona is Medicaid fraud, where they were taking Native Americans, and I know Dan Lauber's on the meeting, and he's very familiar with Arizona in terms of the out of control recovery residence industry and the legislature that was basically asleep at the wheel. They were punishing good providers, and the laws that were passed didn't affect the bad providers because they weren't under the law. In other words, they weren't under scrutiny because they were not registered. But the scam was you just pick people up off the reservation and you bring them in, you say, hey, I got a place for you to live, and you go to treatment. And many of them were not even addicted, but those that were went into a cycle of addiction so they could be recycled into and out of, like the Florida shuffle. It was the Arizona shuffle, only it was 100 billion or more in Medicaid fraud. And they've already indicted 140 individuals, and they've got 200 more that are under investigation. So they're finally getting something from a law enforcement perspective done in Arizona. Interesting stuff. We're not alone in the world, in the universe. We have other inhabited planets, and some are really hurting, like Orange County, California, and Arizona. Okay, so now for DCF, I'm looking forward to this. And hopefully it'll be in a language that I can understand as not being total technocrat. But Angela, do you want to share your screen and walk us through the new LEEDS licensing platform?
Yes, and well, I think so. I'm not sure what. There's been some transition here at the department. Martha Harbin's no longer with the department, so I'm not sure what. When Mary had reached out, Marianne had reached out. She had said she wanted to see the provider search, which is kind of how the public facing can see what's going on. So that's what I was getting ready to show today. I wasn't planning to show the actual licensing system.
Oh, okay. No, that's fine. I did.
And we can talk about doing that at a later date if that works too.
We can talk about that, but I think you're correct. It's how the public can look at the DCF database and actually get useful information, especially from out of state, when they're trying to find a provider or a recovery residence that is attached to like a day night with housing provider.
Yes, sir. And while you were talking about it, I did do a quick little peek. I will have the team do a bigger peek in it, but I do not believe there's any in Okeechobee. But I'll show you how you can look at that through the database when I do the demonstration. Can everyone see my screen okay?
Not yet.
Oh, I guess I need to. I'm used to Teams, not Zoom. So now can everyone see my screen?
Yes.
Okay, perfect. So this is the DCF homepage. So I'm going to walk you through how you can get there. You go to services, licensing, and then licensing resources. And then you want to go to substance abuse licensing.
You're now off the screen. At least my screen doesn't have your.
No, she's gone.
Oh, you're not on what?
No, she.
Angela?
Yes, sir.
There you are. You're back.
There you go.
Can everyone still see?
Yes.
Yeah.
Okay. So that you get to the substance abuse licensing page, scroll down a little bit. I'm trying not to give everybody whiplash by going too fast. And you'll see the view SUD provider search. And so it first comes up a long laundry list of all the providers in the state. There's two different ways. You can do a simple search if you know the name, or you can go into an advanced search if you're looking for a particular area. So I'll click on advanced search first. And again, you can put in the provider name, what city you're looking for a location in. If you know just the county, if you know, you can look at either whether they were active or closed. What type of license they have with us. You can see if they also have psychiatric services at this facility. You can see the provider, what service you're looking for. So that day-night treatment with community housing, that would be your FAR group. And then what funding they take. Do they take Medicaid? Do they take private insurance? Are they getting grants? So all of this information is provided by the provider when they are applying for a license with us. So I'm going to, or you can just go back to and type in a simple name. So I had some providers I wanted to, because I knew they had some of the information I wanted to make sure I shared. So you could look up Eckerd. So I click on Eckerd and I click view. And this is a listing of all of their sites. So while we're transitioning, so statute change where each provider would get a license per component, they are now getting a license for the entire site. So as one updates their license as a renewal this year, they'll transition to that new way of licensing. So if they're in here as our old way, they'll be in here by component. So this is all the top section is all the different sites across the state. And so this group does a lot of, looks like prevention type work with elementary schools. So they're out there hoping to stop any issues before they get started. But then down here, you see their individual sites and you can click on one of the sites. And it has a nice little map to show you where they're located in the state, gives you their address, tells you what components they offer. So this is a Res 2, tells you the hours of operation, what their target population is, their specialized group, which is adolescents. They can house 70 children at this facility. They do not offer psychiatric services, and we don't have capacity information at this time. We're still working on that. But then if you want to see their application, you can see their different applications over the years. So we'll look at their most recent. So it has their license application and all the information they provide. So that's their application. You can see any inspections that they've received. We'll pull up one of their inspections. So this was on their prevention, talks about the findings. They were looking at their activity logs. So with a prevention site, there's not as much inspection to do, but it talks about that they scored 100. So this inspection, there was no administrative actions taken from this inspection because all their files were in order. And then this site has had no administrative actions. So if you wanted to see what the administrative actions look like, let me go to a second. Help if I could spell. There we go. So here's a facility down in Miami. They do outpatient. Let's look at this one. So this one's had an administrative action. So you'll be able to, back in December of 2024, they were fined $300. It tells what the violation was for. They received a class 2 violation, tells what that violation was. It gives the history of it.
Wait, I'm sorry. It was really fast. What was the violation?
Determination, they did not meet something in 65D 30.00421A, determination of need and eligibility for placement.
Got it. Thank you.
And it talks about during the inspection, They identified several areas of compliance issues with the provider's admission and placement processes, and that the ASAM criteria was not used to determine the individual's eligibility for placement in an outpatient treatment level of care. So it was a lack of documentation. And so since they still have a license, that means they paid the fine and they made the corrections necessary for that. So that's where you would find any administrative actions on. And then here's inspections for that same provider. And then if you go into the advanced search, we were talking earlier about Okeechobee. So I'm just going to select any sites in Okeechobee. And this brings up regular and expired, active in and active sites, but you can see the service component that they offer. And I did not see any with day night with community housing. I could have even selected that back here in the search. Let me go back and select Okeechobee. And we know we were looking for those with day night treatment with community housing. I hit search and there are none in the Okeechobee County.
Angela, can I
Yes, sir.
can I ask you a question about picking a more, I guess, a more relevant service provider, like either a detox, inpatient, because I know that DCF, you don't do housing. You contract out to a certifying entity. So the oversight comes from the certifying entity, which is FAR. But I think it would be instrumental for this particular group, since it's the State Attorney Addiction Recovery Task Force, to pick a provider, and I would suggest either detox or inpatient, that you could, we could look at the inspections and any actions that were taken. It might be helpful.
Sure. I have it narrowed down to Palm Beach, inpatient detox, active, and on a regular license. And we're just going to pick one and see if they have any. So this one's in Palm Beach. It is the Haven Detox. So again, it shows the different components. This place has inpatient, Res 1, and intensive inpatient treatment. Those are the 3 services they offer. Let's see. No inspections. They do have an administrative complaint. So this means it probably came in through a complaint, not an actual inspection. So this had a class 2 violation of 65D 30.00432. Individuals must be assessed prior to admission to a service component to determine level of service needed and choice of the individual. Findings indicate that a client received services before being properly assessed for placement using a validated tool. The client received medication on May 19th, 2025. However, the validated tool ASAM was completed on May 20th. So they did the ASAM after they'd already given medication treatment. And they received a $500 fine for this because it seemed the way we classify findings are either widespread, which means it's happening across all the files that we review when we go out. Patterned, it means it happened on more than one, and then isolated, it happened on one file. So since we found this finding on multiple files, they received a pattern violation and they received a $500 fine.
Thank you.
So I can pick another one from Palm Beach if we want, or what else would you like to see?
Well, before we do that, are there any questions or comments so far? In other words, for either to use the tool, or do you want something demonstrated other than what's already been demonstrated? And I was going to ask Susan Ramsey, who has used the old database and now can see the new database. She's got her hand raised. So Susan, what's your comment, question?
Well, first of all, it's certainly a lot better than it used to be, and it gives you more access to information quickly. But the next question is this tied to the other parts of a file? For example, can I get to look at their policies and procedures and things of that nature in this system? It doesn't look like it, but I figured I'd ask.
Not at this time. That is something that has been discussed. We're still working through some of that with legal.
Okay, that's great. And has there been an improvement in the responding to requests for the entire licensing file? Because that's been a problem. If I request the entire licensing file from DCF, sometimes it takes months, sometimes it's sort of hit or miss.
I was unaware of those delays. So if you run across that again, Susan, please feel free to reach out to me and I'll see what I can do to try to expedite that.
Absolutely. Thank you so much. But this is much better. I mean, you can really see a lot more than previously, and it is a little more user friendly.
Good. That was the intention.
Yeah.
Dr. Needle, you have your hand raised. Rachel?
I do. I finally learned how to raise my hand. All right, so I know I'm super unpopular on both sides at times, but I think this is great. But I'm curious about, and maybe there's a better time to talk about this, the opportunity to measure more. I mean, right now there's a lot that looks at, can people document or can they say they're documenting accurately? And do they have the right things in file, which we know if they have more money, they have a consultant doing that and looking through it. I would love for this to, for you to also be able to evaluate actually if they're doing the correct types of treatment, if they are using the right kind of therapists that are required for the different levels, if they're meeting, the needs of the clients more on a, will they actually get better, not can they document and cross their I's or dot their I's and cross their T's. Is that something that's possible?
I'm not going to say yes, not going to say no. That's something that I'll take back and we'll discuss with the team.
Okay. Yeah, and I'm happy to talk to you.
That would be more, so Dr. Needle, I oversee the licensing side of things. That would be more like on a clinical side of things. So I would have to talk to my partners over in the substance abuse and mental health side of the department. That would probably fall more under their scope of practice. From a licensing perspective, it's, did you meet the licensing regulatory standards? So,
and I guess what I'm trying to get at is anybody can write a certain way, right? You can even chat GPT that note now for medical necessity, like they can, or they can pay somebody to make sure their files are right. That doesn't mean that what they're writing is matching what's actually happening in the facility. It's like the process and procedure manual. Like if you use the same consultant, yours is the same, and almost nobody at the facility, at a lot of facilities, some of the better ones, obviously. So sorry if some of you are on. I know some of you are great. Won't even know what's in that, right? Mm-hmm. That's what they show you, but it is not actually what is happening. So I'd love to see if there's a way to really see if they're operating the way they say they are and documenting what is actually happening in the facility.
I will absolutely share that with my partners at the department.
Now let me ask this based on Dr. Needle's concerns. If there's a complaint, let me just give an example, anecdotal. You have a tech that is conducting group sessions, and it's inappropriate. Okay. If you get in, and I understand that from a licensing perspective, you're not going to catch this because if they say the right things in the license, then that's what you have to go on. But if it seems like this database here, this is very useful because you can look and see whether there were complaints that they didn't comply with some of the requirements. And so I use this anecdotal that you have a tech running group sessions. You get a complaint, you process the complaint, and will people be able to, from the licensing perspective, from this database, be able to find out whether there's a provider that's being sanctioned for treatment reasons? Does that make any sense, Angela?
I think so. If it violates one of the licensing standards, yes.
Okay.
If it's from a straight treatment, maybe not. We are working on being able to display valid complaints as well, and how those have been addressed. So it might show up there.
Can I try to answer, Al?
Oh, yeah, sure, Terry, go ahead.
From a provider side who's been through many DCF audits and over the years, and as well as Joint Commission and CARF visits and accreditations. I would say that, to answer your question, Al, that would come up and that would be caught in an audit. There's many charts that are reviewed in an audit, and that is something that is checked regularly, that the person that is providing the type of care is trained, as well as has the credentials to provide the type of care that they're documenting for the group. And to answer Dr. Needle's question, which was great, I mean, I think this task force is a great example of what's right in treatment, which is a full continuum. As Dr. Vinny Pisani said in the 70s, we know that treatment opens the door to the house, but community and mutual support groups and therapy are what build the foundation for long-term recovery. And that, the sober living homes that we have, and the number of accredited sober living homes that we have now that do great work and get their clients involved in the community, that's where really the rubber meets the road. But I think the technical question that Rachel and you were trying to get answered is, does a DCF visit for licensure look in detail at those types of things that you mentioned? Al's question, yes. Rachel's question on whether the type of treatment that's being provided to the client matches what the client needs for success, and what they're, if they're a client with a lot of trauma, are they getting a lot of trauma care? It depends, and that's not something that I think licensure currently looks at. They look at whether you are following your own policies and procedures as you submitted them, which are, what you get licensed on, your policies and procedures, and how you're following through on those. And then, having Joint Commission or CARF as the accrediting body that comes in behind licensure in almost all cases these days. I mean, they look at the person who's collecting urine specimens, how they were trained to do that, who trained them, where's the documentation that they were trained. So it's pretty detailed in many ways. I hope that helps answer some of the questions anyway.
Okay, thanks, Terry. Susan, you have your hand up?
Yes, thank you. My last question, I think, is there going to be a way to look at incident reports that have been provided by the facility to DCF?
So like if there was a worst case scenario, a death that occurred at the facility.
Yes.
We would go out and do an inspection for that. I don't know if we were planning to put the actual incident report online, but if there was an inspection that went with it, that would get posted on the website as well, under the inspection area.
Understood.
And Terry, thank you for that. And, if there is, I will say, to kind of add on to what to answer more for Dr. Needle's question, if there's something that doesn't seem right as we're looking at the client files, we do have clinicians on our team, people with clinical experience, and then we also do reach out to the substance abuse and mental health program office to tap into their staff if needed, if something doesn't seem right. We are out there to look at the licensing standards, but to your point, if there getting the same treatment over and over, and nothing seems to be moving the needle, we do raise the flag and say, hey, this doesn't seem right. Can someone else take a look at it and make sure that those patients are getting the best care that they deserve?
Thank you. I want to put my question in context. Several years ago, the whole idea of doing this upgrade to the database began with Senator Harrell, and I think it was Siobhan Harris was the secretary at the time. And what Senator Harrell ultimately wanted was somebody looking, say a parent is being solicited. Their child has an addiction problem and they're in Ohio, and all of a sudden marketers are descending on them and promising this and promising that. And her ask at the time was that there be some method where a person looking for a provider would be able to see how the provider is doing. It's a tough one. At first, I think ACA does this somewhat, but at first, Senator Harrell wanted a ranking system. And as you went through the process, your office, DCF, went through the process, it became apparent that you can't really do that. Not in the context of DCF's duties and responsibilities. But how do you get a database, accessible database, that can show when a facility is deficient in many ways? They still have a license, obviously, but there are multiple complaints, multiple findings of deficient treatment. And I guess that was my question, and I don't know if there is an answer or not, but maybe it makes a little more sense in that context.
No, it does. So back to the couple administrative complaints that I shared. Maybe your layperson, your parent in Ohio who's getting influx of marketing because they've been trying to find someplace for their child to go. They may not understand what an administrative complaint is even. So could we continue to make some tweaks and improvements on this page to make some of that a little bit more plain language, parent friendly kind of thing? Sure, we can continue to work and refine, open to feedback from this group and others if we need to take a look at that. All of that I think is here. It just may not be in as plain language as some people might need or benefit from.
Yes, it seemed to me that you did have the data, because when you find somebody, you've made a finding, and that's why you find them. And hopefully you can take this back with you. Having it accessible to people in the industry is a lot different from having it an accessibility, a language and search accessibility for somebody who is desperately seeking treatment for their child. There's no perfect way. There's no way to do this perfectly, and you can't rank. But I think if it can be a little more user friendly to somebody not in the industry, I think that would be helpful. If that makes if that.
Thank you for that feedback. That's important.
Okay. Any other? Did you have any more of a demonstration? I mean, this is great. Thank you so much.
No, happy. Like I said, if anyone has any questions, or feel free to. I'll drop my contact information in the chat. So if anyone needs to reach out or has other questions or wants to provide feedback that they didn't share this afternoon, I appreciate it.
Perfect. Thank you. Any other questions or comments? Thank you. If you have a different side, you said that this database only covers one side of it, the licensing side. Did you say there was another part of the database that maybe we ought to ask in a couple of months for you all to demonstrate for us? Or was I not hearing correctly?
So what I had said was this, if you wanted to see how a provider would go in and actually license themselves, that's a different
Okay.
system, the actual lead system.
Yeah, at this point, I don't think we need that unless I get some feedback that people want that information. But appreciate you coming in. Now it's online. Last time we had a demonstration, it was very limited because it was still in progress. So this is outstanding and appreciate it greatly.
Hey, Al, I got a question.
Oh, okay, Michael.
Yes, and I can get in touch with you, Angela, but when we had a demonstration last year, and it was about the provider side, there was a referral log as part of what the providers needed to do when they're referring somebody to sober living recovery homes. And it only gave the option for it to be certified or uncertified. So, two questions. One, Oxford House not being certified, but legally facilities are allowed to refer to Oxford House. And I asked that then, is there a way that we can indicate Oxford House or put that in as part of like the certified checkbox, or has that already happened? And then also, what happens if facilities are referring to uncertified recovery homes?
We find them.
Yeah, I was just going to say that is a great question. Number one, I would highly recommend that at least in the box, you add the words certified or Oxford House, OH maybe, or OH.
Okay.
Just because they are designated. They can refer and receive referrals, provided there's no financial interest. Now, the other part of the question is very important because one way of determining for a state attorney for public safety to determine that there may be, well, number one, a crime, because if you refer or accept referrals and you're not certified or you're not an Oxford House, it's a first-degree misdemeanor. And that was one of the things that we that started this whole thing about getting that into leads, because a provider is required to put down who they are dealing with in terms of recovery residences, even if it is not a day-night with housing facility. My understanding is they're still required by their license to put down whether and who they have a relationship with in terms of housing. Am I correct there? Do you know the answer to that?
Yes. Go ahead, Josh. You are
Yeah,
much
that's correct. So we have a lot of programs that don't have that day night with community housing component. They just have a day night. They may have a separate LLC for the housing. Still, that's a referral. If it's even like if it's a referral, which may not occur often, but from a detox or res directly to a sober living, there's a referral. It needs to be to a FAR certified or Oxford House.
Yeah, and my question is, and again, this is more from a law enforcement perspective, because certified housing and Oxford housing is not the problem. When we look back 10 years ago in Delray Beach, you couldn't throw a stone without hitting a recovery residence, but hardly any of them were certified back then, and most of them were flop houses. So being able to identify a provider would be much less likely to use a sleight of hand and deal with uncertified housing if they were on a database that was easily accessible through the department. I thought that it was even in law. I'll have to check the statute that that DCF was that a provider, not DCF, but a provider was required for their licensing to state who they are affiliated with in terms of housing. And if that's not the case, then we are going to need offline to discuss this. Okay, so we can chat. I'll ask you this question, not in a group meeting where we're moving on to another issue, unless you are
Well, as I say, our team has a great relationship with Josh and his team, and we meet very regularly. We talk about if anything has come to their attention or our attention of uncertified, and we
Okay.
kind of talk back and forth amongst ourselves to try to resolve as many of those uncertified homes as we can. So we
Right.
do have a great relationship with Josh and his team. He meets with my team. Was it now monthly, Josh?
Monthly, weekly, sometimes we talk daily. So see,
And,
We are
I
working to try to
appreciate
resolve
that.
this issue.
I appreciate that, Josh. And like I said, certified housing is the mark. But if I, as a prosecutor or Palm Beach County Sheriff's Office, okay, is investigating um, a house where we think there's prostitution, for example, or sexual assault, um, and the law we can only go against for this part of it, for being for accepting or referring to an uncertified provider. We can only go after the sober home or recovery residence. We can only go after the provider. We can't go. That law doesn't give us the ability to go after the house or the person who runs the house. I mean, we can go after them for other things, patient brokering or, God forbid, human trafficking. But when it comes to the provider being on the hook, and it's important because most providers don't want to violate the law. And we want to make sure that they know they stand the chance of being prosecuted. And so it was always my understanding that there was a way where law enforcement, for example, could look at the DCF, the department database, and determine from a license, XYZ detox. Okay, well, detox is a bad one. Okay, treatment facility, that's an IOP. Okay, and that they would have to list, and we would be able to see what houses or what residences they were dealing with, even though the department doesn't license those residences. I thought they had to put that on their license application and that it was accessible. Something we can talk about. If you don't have the answer to that, yay or nay, we'll just find out what's going on. It may very well be, and I just want to know that it is and it's accessible. It's accessible. Make sense?
Yes, sir. Happy to have that conversation.
Okay. Again, I thought even before this upgrade that it was actually a requirement under, and I'll check the statute, and if it is, I'm sure you all are doing it. Any other questions or comments? All right. Thanks again. And let's move on to the managing entity, Saartf. And I believe that Daniel, you're going to be giving us an update on what's going on.
Hello. Thank you, Al. Appreciate it. Like I said, I'm here on behalf of hi, Barbara. I'm here on behalf of Anne, since she couldn't be here today. Again, apologize for that. But yeah, I can give you a little update on the Connect program and how it's going so far. So the program started rolling out kind of in the very early phases in January, and we have been kind of trying to build it up ever since. Um, in total, the program has served 123 people, which is kind of pretty impressive already. I think probably some of the biggest successes with the Connect program at this point are, just kind of the amount of success that they've had with actually connecting individuals with services, and especially with connecting individuals with housing. We have funded over $75,000 of housing at this point. And there are well over, I think the number is probably around 70 people that have been successfully housed thanks to the Connect program. But it's not just the housing that we're doing that. Because this program is holistic and comprehensive, we're helping those individuals to get connected to the actual treatment and support services that they need as well. Everything from primary care, with a big thank you to the healthcare district that We have that the Harm Reduction Center, who is our provider for the Connect program, they've worked really closely with the healthcare district to get a lot of individuals connected with primary care, psychiatric care, medication-assisted treatment, recovery support through Rebel Recovery, and there's just a lot of things that they've been able to help these individuals with. Our biggest challenge right now with the program is honestly that there is a lot of demand for it, and we're trying to staff up the program. So unfortunately, we're at a point where we've had to slow down the new individuals because obviously because this is a long-term process, right? We're sticking with people over many months. Um, a caseload's been built up in the program now, so we're Harm Reduction Center is actively hiring more care coordinators to try to deal with the continued demand for the program. So it's kind of a good and bad thing, right? To have a lot of demand, um, but um, so yeah, there's just kind of a lot going on, and we're providing a lot of oversight and technical assistance to harm reduction. As they've gotten built up to try to make sure that people are getting the best care coordination possible. And kind of our motto is really making sure that nobody falls through the cracks. That's what this care coordination really is about. It's about making sure that people don't fall through the cracks, that we're sticking with people even when things don't work out, that they have a care coordinator who is on their team, who is trying to help them. We've had many cases where speaking of recovery residences, where housing hasn't worked out for individuals, and the care coordinator and our team at Southeast Florida, we really go all hands on deck to make sure that people don't end up on the street again. Um, so, so yeah, a lot of exciting things going on with the program. It's going to continue to be built up. Lots of work still to be done. Still very early, but we appreciate all the collaboration and support from the community. We have all kinds of providers that are really um, just engaged with the program, want to be a part of it, want to help out by connecting these clients with services. So we're really excited about it.
Thanks, Daniel. Any questions or comments? I have two questions. Daniel, the Connect program sounds like it's more expensive than your old voucher program. Are you still doing the voucher program as well?
Yeah, I probably should have started with a baseline of what the Connect program is. I think that's probably what I should have started with. I apologize. I guess I know a lot of the folks here are probably familiar with the program already, but maybe I should start with that. Was that okay,
Sure,
Al?
you can go backwards and just give us
Yeah.
the 2 cents
Let
beginning.
me go backwards a bit. So basically, the Connect program has been a project that we've worked on with Palm Beach County that uses opioid settlement dollars. Um, that basically the whole point of the program is to help people to navigate the system, right? For people with substance use disorders and co-occurring conditions. So we're specifically focused because, this is opioid settlement dollars. We're specifically using the funding to help people with addiction, and they can also have co-occurring mental illness as well, but they at least have to have a substance use disorder, okay? And referrals are coming from different places, including 211. Individuals who call in to 211 with some kind of substance use disorder, they're looking for help, looking for services, and it kind of goes beyond just a basic referral. The Connect program will step in, assess the individual, figure out what their needs are, determine what level of care that they need, and that's all done by a licensed mental health professional, right? So either licensed clinical social worker, licensed marriage and family therapist, or licensed mental health counselor, or a registered intern. So we have a few care coordinators who are registered interns who are working under supervision.
So that you would be using these dollars sort of as a warm handoff. Is this kind of like a parallel, and correct me if I'm wrong, to what the healthcare district does when people go into the clinic, say North County, and they get a warm handoff to services, and then they follow them through. Is that kind of like what you're talking about? And do you work together, or is it separate?
Yeah, I would say that it's a little more involved in that, a little bit more hands-on.
Okay.
So you really have a care coordinator who is gonna be sort of like the hub. You know what I mean? They're gonna, well, I know there's a place called the hub, but like the metaphorical hub, right? They're gonna be the ones who are connecting you to all the different services. Even if you change providers over time, maybe you start in detox and go to residential and go to outpatient over the course of months, right? You're gonna have those individuals are gonna have that care coordinator follow them through that, make sure that as those transitions happen, that those engagements are effective, that the services are working for them, that again, if they need, for instance, uh, if they need primary care or dental care or assistance with food, that they're getting connected with either a case manager, and in the absence of that, that care coordinator is going to step in and try to connect that person to that service. So it's a little bit more involved in what you're describing, really taking a holistic view and really focusing on those social determinants of health that often are really the key determining factor to people's success, right? When it comes to achieving their goals. Does that answer your question?
Yeah, yes, it does. And are you collecting data in terms of this is a program, and it's always useful to see whether your care coordination, when you're following people for months and then years, hopefully, it's very helpful to know what works. So do you have a specific data collection part of this that you'll be compiling? We could
Yeah,
talk about this
absolutely.
later down the road.
Yes, yeah, we're collecting all kinds of data about everything from how many referrals individuals are getting and whether they engaged in those referrals, right? Did they actually engage in the service that we sent them to? We're collecting surveys directly from the participants to figure out if they are actually getting what they feel that they're asking for, if they're able to achieve their goals. Um, and then obviously we collect data once people complete, right? So if they complete complete is not really the right word, but whenever they close out a care coordination case, we're collecting data at that point too about whether the individual was stable by that point, were they engaged in their services, did they get what they needed? Um, so yeah, we're collecting quite a bit of data, and we're going to continue reporting that here and to the BHSUCUD committee.
Great, thank you. Any other questions or comments? Daniel, thanks a lot. Please, I give my best to Ann.
Thank you. Will do.
We're turning now to agenda item 5. We have Whitney Van Arsdale from DOH Palm Beach County. And they have a pretty good non-fatal overdose surveillance annual report, which, at the beginning, I always give updates and I talk about the overdose deaths. Well, the only difference is a non-fatal overdose just means somebody didn't die. So these numbers are hugely important in determining what we're doing, how we're doing, and what to do in the future. So Whitney, I'm turning it over to you.
Thanks, Al. Let me go ahead and share my screen. And start. All right, y'all should be seeing my screen and stop me if you're not.
We are.
Perfect. So my name's Whitney Van Arsdale. I'm the Overdose Surveillance Program Manager for Palm Beach County. I'm also an epidemiologist. Been studying drug overdose now for going on 6 or something years, so it's been a minute. The purpose of this is we just put out our 2024 annual report. It's a really comprehensive report, 75 pages. So I'm just gonna try to hit the highlights. I'll have that QR code and link at the last slide so you can see it again, but that will take you to our data page and you can see some of our other reports in our dashboard that we put out. This report's part of a broader CDC funded initiative that is trying to use data to strengthen our overdose prevention and response strategies. I'll give a two slide highlight of the syndromic surveillance, which is just basically a snapshot of what's going on. This kind of syndromic surveillance, it's very timely and we can get it really up to date, but it's not very detailed. And so that's why we do our in-depth report. But EMS data, we have hotspots that have been seen in similar years with our zip codes, namely in the Riviera Beach area, Lake Worth. We've had a 20% decrease in EMS responses for suspected overdose from 2023 to 2024. Again, as Al said earlier, we're moving in the right direction and, just trying to keep it up. For emergency department visits for suspected drug overdose, same Riviera Beach area, but we also have a little hotspot out in Western Del Rey. This data is different from the EMS data because the EMS data is incident locations where these overdoses are occurring. The emergency department data is where these people live. So they have similar patterns, but they're different. Again, you can see in 2024, we had a 20% reduction from the previous year. So about our report, about the data, our epidemiologists here abstract data that we get from medical records and other databases to kind of help us understand what's going on. So we identified over 5,000 ED visits for suspected overdose in 2024. We request those records. We try to partner with the hospitals, and we get about 2,600 back. We review those to make sure that they meet the inclusion criteria, which I'll show on the next slide. And so about 82% of those records met it and were included in this report. This is also reflects ED visits, not individuals. So one person may have multiple ED visits, and we have some estimates that at least 10% of the individuals had more than one visit just in 2024 alone. So what's included? Our substances that we monitor have expanded so much since we started this back in 2020. We're always adding more things that we think are relevant or of interest. What's not included, we don't include overdoses on things like Tylenol, or we don't include alcohol or marijuana per our grant requirements, unless they're in combination with one of our monitored substances. So we don't have just alcohol, but if it's alcohol and opioids, it will be included. So most of the overdoses that we had were male, 62%. That's not common. That's similar to other years. Our racial ethnic composition was 64.2% white non-Hispanic, 16.9% Hispanic, almost 16% Black non-Hispanic, and then other non-Hispanic was 3%. Most of the overdoses were among adults aged 25 to 44 with a median age of 38. We have seen this general shift in the past couple of years of people getting older, and it's shifting away from the younger 15 to 24. But when you break it out by sex, you can see that males, they're skewed younger, so most of them 25 to 34. But with females, we have this really hard shift, and it's a heavier in the later ages. We looked at employment. A greater percentage of females were not employed compared to males. And then by race ethnicity, white non-Hispanic and Black non-Hispanic were more likely to be unemployed or not have employment. We did put together a little word cloud to visualize what kind of industries these people worked in. So you have a lot of construction, food and beverage, but you also have hospitality, healthcare, technology. So it's really a vast array of different occupations and industries. We looked at health insurance. 1/3 of the sample did not have any health insurance at the time of overdose. Males, those that were other Another race, non-Hispanic and Hispanic, had significantly higher rates of being uninsured compared to other groups. Females were more likely to be insured through Medicare and Medicaid. White non-Hispanic individuals were more likely to be insured through Medicare, and then Black non-Hispanic were more likely to be insured through Medicaid. Housing stability, we know how how important that is. 1 in 4 patients were experiencing housing instability. That was higher among males, Black non-Hispanic and other non-Hispanic individuals. Females, white non-Hispanic and Hispanic were more likely to have that stable housing. We also look at the number of addresses associated with an individual in the past year. This kind of gives us another way to measure housing instability. Overall, 21% of the sample had 4 more addresses associated with them in the past year. So that indicates that they're frequently moving or might stay and get mail at a lot of different places. And moving to substances involved in the overdose. This data is from either self-reported or clinician suspected data that they include in the medical records and or billing data, diagnostic data. So you'll see some things, and this is just what they think they took or what the provider thinks they took. But opioids, and particularly fentanyl, continue to dominate the landscape. Opioids and stimulant use is more common in males, while drugs like benzodiazepine and anticonvulsants, muscle relaxers, and those things that are more likely to be a prescription, that was more common among females. We did have similar rates of opioid use observed in white, non-Hispanic, and white, non-Hispanic, other non-Hispanic, Hispanic individuals. We're all pretty much the same, about like 70% or something. But then Black non-Hispanic had a lot lower. They were like in the 50%. So they were less likely to use opioids. But they did have a significantly higher rate of stimulant use. And then alcohol use as a co-ingestant, because again, it wouldn't be included if it was by itself. But alcohol use was highest among Hispanic. The breakdown of some of the big categories, opioids, stimulants, and benzos. Fentanyl, again, is the highest proportion. The second highest is unknown opioid, because a lot of times they go to the emergency department, they don't know what they took, or they're not conscious, and they don't, so it gets recorded as unknown opioid. Cocaine is the highest in the stimulant category. I said it before, but a lot of the country is trying to handle the problem with methamphetamine. Methamphetamine has been going up like crazy, but Palm Beach County specifically, and possibly some of our neighboring counties, we have a really strong hold with cocaine. That's our #1 stimulant. And then for benzodiazepines, alprazolam, that's Xanax, that is the top highest reported. Looking at where these overdoses are occurring, females, white non-Hispanic, and other non-Hispanic individuals were more likely to use drugs indoors at like a private residence or a substance use disorder treatment facility, whereas Black, non-Hispanic, Hispanic individuals and males were more likely to use at an outdoor setting, such as on the street, at a gas station or parking lot. The route of administration, oral ingestion was the most common method of use. However, males had a lot lower rate compared to females. Females and white non-Hispanic individuals had the lowest rates of vaping and smoking. And then snorting and injecting drugs, which is obviously associated with the rapid onset and increased risk of overdose. That was more common among males, and then other non-Hispanic and Hispanic individuals. We looked at whether naloxone was administered or not. A little bit more than half received at least 1 dose of naloxone. 23% required multiple doses. And then we looked at who administered naloxone. So EMS, being the first responders, that makes sense. About half of them were the ones that gave naloxone. But then it was really cool to see the bystanders administering naloxone increase. I had to pull up our old report and check, but it increased from 13.6% to 19.8%. So, that's evidence of we're getting the message out. We're saturating with naloxone and all the good work that you guys are doing. We try to capture some of these contextual things, and this is a really hard thing to capture when we're doing a secondary data collection. We're not interviewing these people, so we can't ask our questions. So we just try to comb through and get some stuff. And so understanding maybe some special circumstances relating to substance use and overdose. So over medication or adverse reaction was accounted for about 10%. This would be a lot of like the elderly population. They forget that they already took their medication, so they take it again and they start having, shortness of breath and all that stuff. We also look at when people are self-medicating for stress or anxiety, and they're just, they just have something going on. So we're always trying to figure out a way to capture as much data as we can. Most of the individuals did have a history of substance use that we could tell, about 83%, and 35% had a history of overdose. I suspect these numbers are much higher, especially, the history of overdose. We only have access to certain data. If the patient comes from out of state or out of county, we might not get that. Maybe they went to a different hospital and we don't get that data. So so this is all just kind of like a baseline. And then naloxone prescribing at discharge. We were looking at what happens, after or like when they're leaving the hospital, like what referrals are they getting? Are they getting naloxone? And only 13% received a prescription for naloxone at discharge. This might be because it's saturated. You can get it at so many different places. I can't really speak to the why. And then the ED-initiated buprenorphine and buprenorphine prescribing at discharge, only 3% who had an opioid overdose received MOUD while they were still in the emergency department, and then less than 1% were actually prescribed. So still a lot of work to do there. Other referrals that are made, again, these are some really small numbers, and we hope to increase it as we move forward, but referrals for treatment, such as healthcare district for Matt, the Palm Beach County Health Department, another mental health provider, or things like Rebel Recovery or DAF, all pretty small numbers. So discharge planning should include prioritizing these linkages to care, including like peer support services and follow-up. And I think all that is really, really going to make a difference. And that is my brief walkthrough. I know I said 75 pages, but it's a lot of charts, so it's not too heavy of a read. And yeah, if anybody has any questions, I'd be happy to take them. Oh, Al, you're muted.
There we go. Thank you very much, Whitney. Terry, you raised your hand. Go ahead.
Yeah, great report, Whitney. Thank you very much. That was awesome. Really appreciate the effort and all the work put in that. Very enlightening. Where does 2C fall into? You mentioned cocaine, but what we hear is 2C, 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 and 2C is a combination of anything and everything that we don't even know: ketamine, opiates, maybe some cocaine. Where does that fall?
Stephanie, you're on. You want to field that one?
Hi, good afternoon. From what I remember, we didn't see too much 2C back in 2024. That's more of 2025 that we saw, and it's not so much reported because it's what the patients report. But like Whitney said, if they're unresponsive, the doctors don't write it in or anything like that. So it's what the patients say. And I would say we saw like maybe 5 or so, like in 2025, not too many.
So yeah, like you said, you're not getting toxicology reports that you can review, so you don't know everything that's in their system. But yeah, it's out there. There's a lot of it.
And that's
Thank you,
something
guys.
to see. We are looking at, we've been working with Rebel Recovery and their syringe program to do like a biosurveillance with the drug products and paraphernalia testing. And that is one thing that we are including because we do see a lot of it when people bring their drugs for drug testing. So it's good to know that you guys think it's important, and I'll keep that in mind. So,
Thank you very much.
Al, you're muted again.
I am muted. Any other questions or comments? I had some clarification questions. Whitney, when you gave us the fire rescue suspected overdose transports,
Mhm.
Are you talking about all the different fire rescue departments in the county?
Yes.
Okay, that now that
Everybody that reports into M-Stars.
okay, because as you saw, the numbers that we got from Palm Beach County Fire Rescue that I talked about at the beginning, uh, in 24 there were 1,231. So that's about right because that's a little more than half of all the transports, and that would be representative of Palm Beach County. So um, the it's very discouraging to see the discharges from hospitals, the low rate of naloxone, but more importantly, the low rate of MAT, buprenorphine, coming out and being discharged from hospitals. I know that, and the low rate of referrals as well.
Mhm.
And I know that what you're doing is collecting the data, but do you know of any um, projects, programs, discussions in the Department of Health about how to address that?
Natalie, if you're on, I'll punt this one over to you. You do more work with our partners, but I know internally we do talk about getting more education out to hospitals and really trying to work with them. We have the OFR where we review this information that always comes up about referrals and getting people in, but it's really hard to get people from the ED into our space and get them to kind of like hear us out. But Natalie. Oh, I saw you unmuted. If you're talking, we can't hear you. Okay. Um,
Well,
yeah.
I get that you have no control over what the hospital EDs do. I wish that, and this is the first for since I can remember the meetings that we haven't had somebody here from the healthcare district. I know that you all have meetings on a regular basis, community meetings of the overdose surveillance, and it collecting the data is it's disheartening because I'm kind of stumbling here because hospitals, we've had a hard time with hospitals, even in JFK North. But there's got to be a way, I think, and I will talk to the healthcare district. And Daniel, maybe you talk to Ann Berner about this, about having some way, even on the weekends when the most overdoses would come in, um, to have a peer at these hospitals, to have some resource to be able to do a warm handoff from the hospitals as opposed to just discharging to the street. We know where that leads. That was part of the catastrophe that was going on 10 years ago. You walk into a hospital emergency room, say JFK Middle, not North, but Middle, and I've done it in 2018 with Dave Ehrenberg, And I counted at least a dozen young adults, mostly male, that were nodding out, sitting in chairs. And it was pretty obvious talking to the staff that they were all in there under observation for an overdose. They were delivered by fire rescue. And then they would be discharged to where they're now in withdrawal, after Narcan, after they've been revived. So the rate's going down of overdose deaths, but we're still seeing multiple overdoses with people. And I think that may be the next step, is basically getting the silos together to figure out how we can do a better job of the discharges for drug overdose that are leaving the hospitals, with 1% of them get a buprenorphine or MAT prescription. And I don't know, what was it, 2.7% that were, maybe 4% that were referred to DAF or to healthcare district. I mean, that's, wow. Good to have the numbers. Good to have the numbers. And one last question. Years ago, when you made a presentation.
Can you hear me?
Yeah.
Oh, sorry, I was having mic issues. This is Natalie Kenton.
Oh,
Yeah.
hi, Natalie.
Hi.
Let me just posit this question before you make your comments, so then I'm done. Are you getting all the hospitals, data from all the hospitals? Because I remember you had some where you had
Yes,
contracts.
we still
with
have
radio
that
data.
issue.
We still have the issues, yes.
Three hospitals we don't get any data from.
Huh. Is there, I mean, I don't want trade secrets or I don't want to get you in trouble, but is there any reason why the 3 hospitals are not cooperating?
They are not responsive. We try to leverage certain relationships, reach out multiple times, but we don't get any response. I don't know if it's coming from us as the Department of Health, but and we try to express this is not a blame game. We just want the data to show what's going on in the community, but they're not very responsive at all. We try to go into the spaces that the ED is, but we get a lot of pushback. So in terms of getting that information and education out into the EDs for the referrals and the buprenorphines and stuff like that, it's difficult. We do our best, but we welcome any help. We try to invite them to the OFR in the conversation, so that they can see the data, what we're seeing, the multiple ED visits. So, whatever recommendations we can come up with, but it is a very challenging to get hospital participation, and to get them to listen to us in a sense. So we do try our best, and we'll continue to leverage relationships. But that's one of our focus we're trying to do now, doing more outreach. Palm Beach County Fire Rescue is also going into the ED through their mobile integrated health and the work that we do there. So we're hoping for, as we continue with the grant, but it has been a very difficult journey, especially to get the hospital systems.
Well, if there's anything that you can think of that this task force can do, or any of the different entities that are on the task force, let me know. It's a problem. You've identified a problem, and the hospitals are not helping with the solution. I can't say it any other way. And I don't know how we can, whether we even need to get the Chamber of Commerce on board or something.
I know a couple of the recommendation was to get leadership from the hospital system, like FMA or something like that. But we're going to keep trying.
Okay.
See if we can get them to the table, and we appreciate any help. And we'll reach out and to you, Al. We'll discuss with the team as to which the hospitals. We'll send that to you, and then see who we can get on board and who to come to the meetings so that they can see.
It's a little late in the process, but maybe we can get some of the opioid dollars to offer them, so that I get a hospital not wanting to pay money or expend resources if they're not getting reimbursed. I mean, that's the playing field that we're playing on. but we're allocating a lot of resources through the opioid dollars, and we need to pay attention to this. This is the front door. We're always concentrating on JFK North and getting people from the ER transported to say the healthcare district, and in some cases getting Saartf, the managing entity, involved. But we're really losing. We're not getting the front door of the hospitals still. And okay, anybody else have any? We have some. By the way, Barbara, I am so sorry for your loss. There's more than that. You have your hand up, and please, but I just, it's a lived experience that tragically so many people have had to go through. But go ahead, Barbara.
So thank you for that. I appreciate it. I've kind of gotten to the idea in my lifetime where the disease of addiction, it does take lives, and it doesn't matter, whose life that is. If you do drugs, this is just a consequence in some applications. I do want to talk about the hospitals, and I thank you so much for what you're stating here about the hospitals. We went in as an agency for lived experience, and when we went in, I did a tour with some of the case managers, the ER staff. They didn't want to talk with us. However, at the same time, one of the doctors said, "Oh, you guys are here about people who are using drugs. Let me show you something." They took us to an observation floor. They have a whole entire floor that are people that are in the emergency room who go to an observation floor who have come in by overdose. So we found that floor, and we go to that floor every single day. We have a peer specialist in Indian River County that goes there every single day. We've gone to all of the other hospitals and had conversations with them and said, we talked to them about the stigma, and we realize, but we want to help you save money by people who are returning that have Medicare or Medicaid, right? Because they lose money that way. And then also we want to help these individuals be discharged so that way we can follow up with them in a care coordination manner and follow them for up to a year or 2 years in order to make sure that they're living their life. Well, the hospitals hear this, and they call us frequently to come into the hospitals in the Treasure Coast. So I don't know if that's an option that you guys can put forth in Palm Beach County. That's been our experience, and it wasn't easy. It wasn't easy. We beat down the doors until we have finally met the right people and who are willing to support us in our efforts to help the people within their hospital. Yes, thank you.
Barbara, first of all, how many hospitals were you beaten down the door at?
All of them.
Well, give me a number, even if it's less.
Let's see, Okeechobee, Rollerson, Cleveland Clinic, Orlando Health, the Cleveland Clinic's 2 in Martin County, and 1 Tradition. We have HCA, and then all of the standalone HCA emergency rooms. So I would say 15.
And how did you get them to listen?
We just kept showing up and doing the work.
What's Barbara? I know you're in the Treasure Coast. What's your who do you represent?
I represent Right Life Services, and we're a peer-run, peer-led agency. And we just make it happen. We go in and we talk to staff and we meet with them until they finally say, okay, let's get you connected with this doctor, or let's get you connected with this case manager. So now we have all the case managers who call us, directors of case managers, the social workers. We have doctors who want to come to, when we train peer specialists, they want to come in and help us talk about their medications and, their primary health care. So we've made an impact in the Treasure Coast as it relates to hospitals and those people who use drugs.
Do you have funding for peers? I mean, I know that some of the hospitals resist even having anybody in the hospital, whether it's for liability reasons, because they're not hospital staff or what have you. I think we'll go offline because you may need to do a presentation in a future meeting to walk us through. So we need what you did in the Treasure Coast here in Palm Beach County. Because for too long, the hospitals have been ignoring this problem and just saying, hey, this is not our job, not our monkey, not our circus kind of thing. So
We got that too.
we'll talk.
Yes, thank you. Yeah.
Thank you. Okay, Josh, you got your hand up?
Yeah, thanks, Al. So I really can't speak to the hospitals, but I can tell you some work that we're doing in Broward County with their the Broward County Department of Health Overdose Fatality Review Board. So it's a group that's there to identify gaps. They review the overdose fatalities and see where there's gaps, how the community members and stakeholders can fill those gaps. So one thing that we're doing now, we've connected with the Department of Health there, and they have their providers like Susan Mora's group, which is South Florida Wellness. There's South Florida Opioid Alliance, the Robin Foundation. They provide free Narcan training and distribution to FAR certified residences. So we've been in a project now for a couple of weeks, reaching out to our providers, letting them know that this is free training, free Narcan. So they'll even install the cabinets there at location. It doesn't cause any damage. It's just kind of stick on the wall. But it's a win-win for everyone. So it's more Narcan is in the hands of those who need it. And especially when they discharge, they re-up any kind of Narcan that it's expired or that's been used or taken. All the provider has to do, if they're FAR certified, is call them, they'll come back out. And they'll train, I'm assuming, as much as the provider would need.
Well, does this involve the hospitals out there in Broward?
Does not involve the hospitals. I'm saying I can't speak to the hospitals, but
Okay.
because I did notice those numbers, that 13% at discharge didn't have any kind of Narcan either, and that made me think of discharges coming from treatment centers and sober livings and stuff like that. So we want to make sure it's in those hands of those individuals.
Is there any benefit, do you think? I mean, Natalie and Whitney are on the meeting for them to reach out to you and emulate the plan that you do that you've done that you have in Broward?
We do something similar, Al, with our coalition here with the naloxone boxes, and we distribute naloxone as well. So we try to get it out to all of our community partners. So they distribute it. We provide the bulk, and then to all our community partners, and we always distribute it at our OFR as well. So and to fire, whichever one of our partners need it. So we do a similar process in terms of getting naloxone and asking anyone who needs a naloxone box, and through the coalition, they're able to get those boxes. So a similar process. Can't do it on the hospital grounds because we tried that, and it was I forgot what they mentioned. You can't have the naloxone out there because what they do in the hospital is prescription wide. So it was kind of we're not able to get them on the hospital campus, but we have a pharmacist that we for our academic detailer. We're going to try to do a lot more outreaches to the EDs and on a peer level. So we're hoping to have more, be more persistent. I think sometimes when it's coming from the Department of Health, we get a little bit more pushback as opposed to if we're not working with the Department of Health. So that's my opinion. So I think that's where maybe Barbara that gets more in, whereas from us at the Department of Health, it's a little bit more of a pushback because they, how they see us. So we'll definitely take some tips and reach out to Barbara and see, how we can be a little bit more persistent with our partners and out there into the community.
Yeah, I wonder if there's something the legislature can do about the hospitals. Anyway, good stuff. A lot to think about. The war's not over, and we certainly have a front that just opened up or has been. And thank you very much, Whitney, for the presentation. Natalie, thank you for your thoughts. And we can move on unless there's any more questions or comments. Okay, the last thing we'll be discussing is the legislation.
I promise you it's gonna work.
What's that?
I promise it's gonna work.
Okay, no, we're not going to shred the evidence, as they say, and go the evidence, the legislation, not this meeting. Many of you know that we were going to have a public working group meeting. I just want to, by way of explanation, say that it was brought up, and the person that brought it up declined to be on the group because they didn't have any criticism or changes to the legislation, because we made a lot of them last year. I know we have Dan Lauber on the meeting, the architect of from Illinois, the architect of this threading the needle between federal law and communities that maybe are NIMBY or maybe don't want to have recovery residences and other community residences for disabled persons in their towns. We're still working on this. I did reach out, and I don't know, Josh, if you know this. Well, you do, because you're on you were CC'd. Reach out to FAR to get FAR's perspective. My understanding is from the chair that they're all going to hunker down and come up with some language changes. I know that there's an issue with any kind of a spacing distance, and I hate to be a broken record, but right now the spacing distance currently in Chapter 419 is 1,000 feet, which we all believe violates federal law. And the other thing is 500 feet from any single-family residential neighborhood for a community residence. So we are going forward. Hopefully, I'll be receiving some suggestions from FAR. And whether I do or not, we want to have legislation in by midsummer to the staff in the Senate and in the House. And we want to have, we know we have Senator Harrell that will be sponsoring in the Senate. We have Representative Rob Long, who sponsored this last year. And if we have any other representatives that want to sign on, co-sponsor, or be a part of this, we're going to be pretty active in trying to get somebody. For those of you who are new, I really ought to go back to the beginning. I want to welcome everybody who's here from the Treasure Coast. Barbara, I know you're not the only one, because when we did when Josh and I and Ted Paddock did the meeting, the panel out in Port St. Lucie, a lot of people were interested in coming to the meeting. Representatives or people running for office as well. So welcome for those of you who are on the meeting, and you will be invited to the next one as well. We have a list, and the list is ever growing of invitations. But what 419 is trying to achieve, in a nutshell, is to clean up zoning and make it more consistent around the state, to require, instead of voluntary certification, to require certification or licensing for a community residence or the equivalent, whatever, if there's no government entity that licenses or certifies, so that we can protect the residents by having standards in place, on these homes, these community residences, and to be able to not only protect the residents, but for the first time in the history of Florida, or in most municipalities and counties that have a definition of family, have an opportunity for these community residences to be a permitted use. In other words, you don't have to go through the tortures of going through a zoning process where you have to have hearings and you have to spend a lot of money, and you have the citizens with torches and pitchforks coming in saying, not in my town. Because we believe so much, we as a state believe so much in the mission of FAR and in Oxford House, particularly because this task force is about substance use disorder and co-occurring disorder. But it does apply to all. You can't just apply the FHA, the Fair Housing Act, and the Americans with Disabilities Act only to one disability, which is substance use disorder or co-occurring substance use and mental health disorder. So, houses with autism, houses, that have licensing through ACA, that are community residences. They're not places where treatment is happening. All are in one pot. And for the first time, we're trying to push legislation across that would allow most residences to be a permitted use. Most probably 95% of residences would be a permitted use because there's a block space distance, about 660 feet, between these community residences. So there's not a concentration of community residences within a block or within a particular community. So that's what 419 is. We would like your support when this does go in and this is filed. And we also would like any read it and also read Dan Lauber's study, which was the basis of this, kind of like what it is a statewide ordinance. It's a minimum standard. Municipalities can give greater latitude. Municipalities can have no spacing distance at all if they care to. But this would be the most restrictive. The floor, the ceiling, I guess, the floor. This has been in the works for about 3 years. With that, I open it up to anybody with a comment. We're not going to go through the legislation this meeting. We'll have a special meeting for that, and you'll all know about it. And does anybody want to make a comment or ask a question? I see, Dan, you have your hand up. I was going to ask you to speak anyway, so go ahead.
I just want to encourage everyone interested in this subject to, if you at least, if you could read the study, that would be great. If you don't want to read all 177 pages, which, as I've noted, will cure insomnia if you try to do it in one sitting, each chapter has key takeaways at the beginning, about 10 key takeaways. That would give you a good idea of what's proposed. But the key thing is this would open up the entire state. I'm seeing more and more cities that have incredibly exclusionary zoning treatment of community residences, cities that limit them to 6 people as of right, cities that have 1,500 foot or 2,000 foot spacing distances. These are all under federal law, I think, quite illegal if you take all the federal law together. And you've got cities that have no definition of family at all, who are imposing these requirements or imposing the state's requirements. But when you don't define family, you can't regulate community residences, including recovery residences, through your zoning. They have to be treated exactly the same as any other family. The only time your zoning can apply is if you have a definition of family that sets a cap on the number of unrelated, which is perfectly legal according to the Supreme Court. Say a 4. Any community residence with 4 or fewer people is a family like anybody else. No spacing applies. The city can't require a license. It's in. But if you exceed 4, ordinarily you can't have that number of unrelated people live together. That's when you make the reasonable accommodation. And what's proposed in this legislation based on the study is that the family community residences that are relatively permanent living arrangements, at least 6 months, are permitted uses in all residential districts. Any place of residence is allowed as long as it's outside of a block, typically 660 feet or 9 lots of an existing community residence. It's licensed or certified and it doesn't exceed 12 people, but we also have further reasonable accommodations made from that to locate within the spacing distance. And that is explained, how to do that is explained in great detail in the study, because there are a million circumstances where another community residence should be allowed within the spacing distance. What this process does, there's an appendix with the application form that Pompano Beach uses, which is one of the about a dozen jurisdictions that have adopted this approach in Florida. That's 5 pages long, takes an hour to fill it out, as opposed to what some cities are doing, where they have 31 items that they want tons of information on, and it takes days to complete. And they're requiring you to get a special use permit or go through a reasonable accommodation process under Senate Bill 954 that passed last year, that has made it tougher on operators to establish new recovery residences. So this simplifies the process. It opens up the whole state. And in the cities that have adopted this, and you need to know this, 95% of the proposed community residences are permitted uses. They just need an hour to fill out an application. They don't even have to hire an attorney, which I realize cuts into some attorneys' income, but it makes it so much easier for the operators. And it protects neighborhoods from being turned into what are effectively de facto social service districts, and helps preserve the ability of the community residences to achieve their core goals of normalization, community integration, and the use of non-disabled neighbors as role models. And I will now shut up.
Thank you, Dan. In a nutshell, I believe we all agree it's in the best interest of people with substance use disorder and co-occurring disorder that there be more housing available, more sober housing. And the trick is to be able to defend the expansion of housing, more housing, to make it easier for the housing to go and open up. Because we're only including, and it's going to be mandatory, that these houses are certified, or they are Oxford houses. Or if there's another Oxford type house that comes up that is recognized by Congress, it could be that too. But the communities benefit because you're not going to have flop houses, you're not going to have uncertified housing. That's not going to be permitted unless a municipality just welcomes it in and doesn't care and doesn't call it, a community residence. But again, Dan and I both use too many words to express a very simple concept. This is going to move the bar dramatically to be able to expand housing for FAR, I believe. Because it's easier to open up a residence and a residence that's doing it right. That is a good neighbor, that is has rules and has resident safety and resident rights in mind. So with that, any comments, any questions? We can go out of this because we weren't going to go through the legislation anyway. See what I received from FAR. Hopefully we can work something out that both the League of Cities and the Association of Counties agree with. Right now, we're very pleased in the last couple of years because, again, it is in the best interest of communities to make sure that when there is community housing, that community housing is safe, good neighbors, and is not clustered. And so we very, very pleased that I believe we have this chance in Florida to be the first in the country to be able to have a process like this, mandatory certification along with permitted use. And I wanted, Terrell, I know your hand's not up, but if you wanted to comment, I wanted to give, since you would have been on the working group, I wanted to give you a chance to comment, maybe a last comment on the issue for today.
I think you've really summarized, and you and Dan have summarized and covered it very well. I have encountered with other cities that just are not as well versed on this issue, where unfortunately, whether intentional or not, roadblocks are sometimes thrown up whenever recovery residence is trying to locate there. So I do think that there really is some validity and some I do think it would be extremely helpful to have the state statute updated to provide for the ability to locate within municipalities and within counties as a permitted use without having to go through a whole reasonable accommodation process. And I can't overstate how helpful that really would be. I think it also would be helpful to staff of the cities and counties that sometimes are, forced into the middle of what could be a political decision and really shouldn't be. And so I think it would help everyone across the board. So to the extent that we can help move the dial on this, I'm really hopeful that this year we will have some success in doing that. And hopefully we can reach agreement on what the language will be. I think the draft that's out there now that went forward last year was good. That being said, we can always refine it and make it better. So I'm looking forward to working with whoever's going to be working on this, and hopefully we can get this moving.
Thank you, Terrell. And just a postscript on that, the carrot and stick, this also, by making this uniform, it will prevent local government from getting sued. Because all this, if they comply with the law, they're complying with federal law as well. And many of you know that Boca Raton had to pay out several $1 million, I believe, 10, 15 years ago in a lawsuit because it was a NIMBY situation. It's interesting that the current 419 does not even include substance use disorder as a disability. It's because 40 years ago, when 419 was concocted, it wasn't even seen as a disability. And DCF is soldiering on, but had this whole process been worked out, understanding the disease that substance use disorder is, ACA probably would have had substance use disorder from the beginning. DCF is doing a really good job, but it's really out of their wheelhouse. But that the law requires them to do it. But this is part of the issue with recovery residences is they're not even under 419. So as Terrell said, there are some municipalities that are requiring 1,500, 2,000 feet. So that's the other benefit. It becomes uniform across the state. Local government is not going to get sued. They're protected. The people, meaning all residents who are not disabled, are protected because there's oversight and there's certification or licensing of the community residences, and it's a win-win-win. So look forward to speaking to you again in August about this. If there is a reason to have a working group working on changing the language to the statute, you'll all be invited. With that, I think we're done. Again, if you just signed on, I welcome you to read the articles that we sent out as attachments about what's happening in Arizona and California, Orange County, California. We've really come a long way in Florida the last 10 years. My hat's off to Mike Caruso, who's now our clerk in Palm Beach County. But when he was in the House, he soldiered legislation that has made Florida the template for the rest of the country and how to do it right. And the same thing with Senator Gail Harrell. So thank you very much. Anything for the good and welfare? Anybody want to make a comment? If not, we're signing off, and we'll see you in August. We'll let you know when the meeting is.
August 12th.
Oh, sorry, August 12th. Thank you very much, everybody. Bye now.